All right, so let's look at the glenohumeral joint, which is part of the pectoral girdle, which is part of the shoulder complex. So a lot of people use different words, but just remember there's many joints of the pectoral girdle or the shoulder complex. Previous videos, we talked about the sternoclavicular joint, acromioclavicular joint, and now we're going to talk about the glenohumeral joint or the GH joint, meaning between the glenoid fossa and the humeral head, the GH. And then we also have this like weird non-joint, the scapulothoracic joint, which is where we talk about the movement of our scapula. And the movements of our scapulothoracic joint assist our GH joint motions. So we do have a wide range of motion at the GH joint in all three planes, and actually a fourth plane or a fourth motion that we have at the GH joint, which gives us tons of range of motion and movement. But we also, it's common to have instability problems. So rotator cuff impingements, subluxations, and dislocation. So basically, the price of mobility is reduced stability. So just to reiterate, the GH joint or the glenohumeral joint is an articulation between the glenoid fossa of the scapula, seen here, and the head of the humerus. It is a ball and socket synovial joint, and it is the most mobile joint in the body. The glenoid fossa is much smaller and shallower than the humeral head. So this is actually a great picture to see that. So if you look closely at the glenoid fossa, it is kind of dwarfed by the humeral head. The glenoid labrum significantly enhances the fit. And so you can see we have the glenoid fossa cartilage, and then we have the glenohumeral ligaments, which we'll talk about in a minute, that kind of circle. And then you have all these muscles, supraspinatus, infraspinatus, teres minor, and subscapularis tendons kind of like encircling it. And those are our rotator cuff muscles. So let's look at the ligaments. You have your glenohumeral ligaments, superior, middle, and inferior. So these are anterior, trying to keep that humeral head articulating with the glenoid fossa. So they provide support anteriorly and inferiorly. We have some ligaments we've seen before. The coracoacromial ligament doesn't cross a joint, right? It's connecting two parts of the same bone, and it provides a roof for the subacromial space. So here's the acromion process. This space in here is where you can get quote unquote impingements. And then we see the acromioclavicular ligament and the coracoid clavicular ligaments. All right, ligaments are lax until extreme ranges of motion. So remember, ligaments can only resist tensile loads. So they're like rubber bands. The more you stretch them, the more resistance they provide. And again, just to reiterate, stability is sacrificed to gain this really incredible mobility of our upper limb. However, you can see frequent injuries, especially in some sports that really challenge the structures of this joint. And it does rely on muscles for active and dynamic stability, and that is the rotator cuff. So sometimes when we hear the rotator cuff, we think that's what rotates and moves our glenohumeral joint, but actually it's just a dynamic stabilizing unit that are basically like holding on for dear life so this humerus does not disarticulate with this scapula. So let's just look specifically where this mobility of the glenohumeral joint comes from. We can move in flexion extension, in the sagittal plane, about the medial lateral axis. We can move in the frontal plane, AB adduction, about the anterior posterior axis. We can also internally and externally or medially and laterally rotate about the longitudinal axis. And then we have this motion called horizontal AB and adduction. And that is when you abduct your glenohumeral joint to 90 degrees, then go towards the midline and away from the midline. Basically the motion that we use during a bench press exercise or a push-up. And then if you have flexion extension and ABA adduction, you can circumduct at the joint. And that is basically when you do arm circles in PE class. These are the osteokinematic motions, and we also have arthrokinematic motions. So let's look at these motions. So here we're looking down on this person. If they bring their arm towards the anterior, that is glenohumeral flexion. If you go in the opposite direction, your arm goes posterior to you, that is glenohumeral extension, again in the sagittal plane. Moving to the frontal plane, right, we have AB away from the midline and adduction toward the midline. And remember, the midline is going to be mid-torso. Then we have in the transverse plane, and sometimes you can see it better if you flex your elbow. If your hand comes toward your midline, that's medial rotation or internal rotation. And if your arm goes away from the midline, this is your midline, then it is lateral or external rotation. And then again, we're looking from the top down here. If you abduct your glenohumeral joint, so your arms are kind of 90 degrees out, and then you move your hands toward the midline, that is horizontal adduction. And if you move your arms away from the midline, that is horizontal abduction. And I just wanted to remind everybody of this concept called scapulohumeral rhythm. For us to get these ranges of motion of, say, abduction of 180 degrees, you have to also have upward rotation of the scapula. So the scapula rotates 1 degree for every 2 degrees movement in the humerus. So if the glenohumeral joint is going into abduction, your scapula is upwardly rotating to allow that increase in range of motion. If your scapula did not upwardly rotate while you were, say, abducting your glenohumeral joint, eventually your greater tubercle of your humerus would hit your acromion process, and you would maybe get about 90 degrees of abduction. So just a reminder that the scapular motions that we talked about in a previous video coincide with these osteokinetic motions at the glenohumeral joint. Here we can see an image with glenohumeral motion. So we're seeing that the GH joint goes to 180 degrees of abduction. Again, I don't like this image because it uses the term shoulder. Shoulder, I think, is much more too vague of a term. But to get this humerus into 180 degrees of abduction, you had to have upward rotation of your scapular thoracic joint to allow that. You also had motion in your AC joint and your sternoclavicular joint. So it's actually quite a complex feat to get your hands basically above your head, 180 degrees. And as it says here, at least 2 motions of your sternoclavicular joint, 1 of your acromioclavicular motion, and then 2 GH motions. And I'll just take this opportunity to remind you of there's arthrokinematics that occur when we are, say, abducting the glenohumeral joint, right? Deltoid muscle is a major abductor, as is supraspinatus. But to get this large humeral head rotating within this glenoid fossa, you're also going to have roll and slide. And here's a more detailed, so it's rolling posteriorly and sliding inferiorly. So just remember, arthrokinematics is the roll, glide, and slide. Osteokinematics are major motions that we talk about that occur at joints.